Okay. So still talking about thyroid disease, except now we're talking about the hypothyroid. And obviously you see a lot of the opposite effects, hence the, big dog, lazy weight, um, sleeping on the registers, I am recording. Thank you, Jasmine. And just kind of lethargic, sleeping, lazy. And, the big thing sometimes is weight gain. And I'll stress that maybe the owner says, they've not changed the diet, they've not decreased activity, but yet in the face of no changes, the animal gains weight because the metabolic rate is changing. The metabolic rate is decreased because that's what the thyroid hormones do. And so when we look at diagnosing hypothyroidism, number one, when we do our physical exam and our history, I kind of put here, when you decrease T3 and T4 production, hypo, it's going to decrease metabolism. And so and C/S means clinical signs. So I'm just trying to kind of abbreviate some things, but then you're going to see what are the clinical signs of a decreased metabolism, which is sleeping a lot, gaining weight, even with no dietary changes. And sometimes the owner may try to increase activity and they're still gaining weight. Maybe they start taking them on longer walks. But the recent weight gain, especially with an owner that's trying to get them to lose weight and they're still gaining weight, is one of the key signs. So, and then the alopecia, which is they can, especially, it's kind of seen more on the tail and on the flank, which, like the lateral sides of the abdomen. And usually, something I stressed yesterday is the alopecia is bilateral, meaning we typically see it on both sides, not just like a one-sided alopecia. Now, how we get to diagnosis, again, the number one thing is we usually have them do a CBC and a chemistry panel because you usually start with that. And what happens is if you do a general chemistry panel, sometimes the cholesterol is elevated due to this altered metabolism. Now, again, dogs, because they don't eat the high-fat diet and things that we do, we don't see a lot of cholesterol problems in dogs. But because of the altered metabolism, sometimes the cholesterol, it can be elevated. And sometimes on the CBC, they can be anemic slightly, and it can be a non-regenerative type of anemia. And then obviously, if they suspect hypothyroid, they're going to want to order that thyroid testing, which again, yesterday I said that testing is usually a special test. It's usually not part of your general, what we call a general health profile. A CBC and a chem is kind of an overall picture, a blood picture of the animal. And usually if you want to do this thyroid testing, which it's the same test that I list for hyperthyroidism, you're going to look at your T3, your T4, and definitely you can't forget TSH because again, it is made by the pituitary and it's signaling release of these thyroid hormones. So is there an issue where TSH isn't stimulating the thyroid? So in this case, so once we diagnose this, and this is treatable, but again, it's an oral medication for life. This isn't curative, okay? So what's happening here is that we have to supplement thyroid hormone because for some reason they're not getting enough thyroid hormone released from the gland. One of the number one meds we use is levothyroxine sodium. In the clinic, now I wrote RX to the side because when I was doing the PowerPoint, I couldn't get the little R with the circle. These are the trade names: L-thyroxine, Siloxine, Thyrotabs, Thyroform. So depending on what your clinic carries. And what's interesting, and maybe if you're at a clinic, if you look in the pharmacy, usually you'll see a row of, we had Siloxine. This is what I remember from practice. And where you had the Siloxine, you have 0.2, 0.4, 0.6, 0.8, 1.0. We had a whole row of bottles because the doctor, based on the blood work, and the animal's weight is going to figure out a dose. Now, this is typically started as a twice a day medication. So once in the morning, once at night. And then somewhere after 4 to 8 weeks of medication, what they need to do is bring the animal back in, and then you're going to repeat the thyroid. Now, if I didn't make this a point yesterday, usually when we diagnose hyper or hypothyroidism, you do the whole thyroid panel. Normally, when an animal starts thyroid medication, sometimes we'll only draw what's called a T4 level. And sometimes the doctor will only measure one, of those thyroid tests, because obviously a thyroid panel costs a fair amount. Sometimes the owner is not going to have to repeat that entire panel. You can just do what's called a T4 level and just check that level. But what we need to do in these initial weeks of treatment is make sure that the dose is meeting the needs. And basically we measure that by how much circulating thyroid is in the blood. And then once we hit normal levels, then they can probably, the doctor might want to see them every 3 months or 6 months to repeat that test. But initially, and the medicine isn't expensive. So the thing here is that owner compliance is really going to be key. You have to have an owner that's willing to give twice a day medication, an owner that's willing to come back and do lab work. So again, client education, making sure they understand, and this isn't a quick fix. You can eventually, it depends on how well the patient responds to the medication. I think they said up to 20 to 30% of patients do not respond. So again, you hope to find a dose that will actually work for the patient, and you could decrease it to once a day. But again, you have to do the blood work and you have to look at the clinical signs. Are the clinical signs improving? Oh, lovely, they're fighting over a bone. Are the clinical signs improving? And, is the patient becoming more active? And, the weight loss isn't going to be like a snap of the fingers. They're still probably going to have to do like extra walking, maybe cutting back calories. But the hope is if you get them on this thyroid medication, you're going to start to see an increase in activity level, and you're going to start to see some of that weight loss. So are there any questions about hyper versus hypo? Okay, and again, hyperthyroid is typically cats. Hypothyroid is typically dogs. Oh, let me mention, I forgot, I kind of went past this. Imaging, if we're going to diagnose it, again, the thyroid gland may be somewhat enlarged. In hypothyroidism, it could actually feel normal. Anytime there is an enlargement of the gland, there is the potential to ultrasound the thyroid to actually look at it. And what an ultrasound does is it looks at the texture of the gland. Does the texture of the gland look normal? Now, an ultrasound, and I'm going to make this comment as a very broad comment. When an animal gets an ultrasound, and sometimes we ultrasound abdomens and maybe you see a mass, an ultrasound cannot tell you if it's cancerous or not. The doctor can look at it and say it's suspicious, because sometimes a cancerous mass will look different than like hyperplasia, which looks smooth. But the best way to tell if it's cancerous is to do a biopsy. So I put plus or minus, because you're not going to ultrasound the thyroid and biopsy every dog that comes in that you think is hypothyroid. Most of the time you just do lab work, you start them on medication, you maybe change the diet, exercise plan, and that's it. But there is the option, again, x-ray of the thyroid isn't going to be as useful because it can maybe pick up that there's something enlarged, but the ultrasound is more specific to look at the texture of the gland and will give you better information. So I didn't want to get past that. Okay. So now we're going to talk about diseases of the adrenal gland, and we've got two that we talk about, and again, are kind of like polar opposites: hyperadrenocorticism and hypoadrenocorticism. So let me talk about hyperadrenocorticism, which is known as Cushing's disease. And you may have heard of this. And what the issue with, and again, adrenocorticism, we're talking about the adrenal cortex. So remember, the adrenal gland is, it looks like one gland. It's actually two structures. There's a cortex and a medulla, and they produce different hormones. If the cortex is releasing too much cortisol, excessive cortisol, and remember, and HM means hormone. I was trying to abbreviate things, but cortisol is the main glucocorticoid hormone. Remember, glucocorticoids are a group of hormones released by the adrenal cortex, cortisol being the primary one. Now, in normal situations, ACTH is released from the pituitary, and it stimulates the adrenal cortex to release cortisol. Typically, when that happens, then cortisol levels rise in the blood, usually in the face of stress, kind of like fight and flight or stress. This is when this usually happens. In this situation, you know, this is how they're going to normally respond to fight and flight. So first of all, cortisol is needed to give us, and think about, you have to think about this. Go back to what fight and flight is. What happens in fight and flight? Increase in heart rate, increase in blood pressure, which increases blood flow to the muscles. Also, a release of glucose. And that boost in glucose gives the energy to the animal for fight and flight. But normally, fight and flight is like a quick event. And then, you know, and someone asked me once, they're like, what's stressful for a dog? I mean, my dog loses his mind when somebody rings the doorbell. And that, you know, they're prepared to protect the house, and that's stressful. Or sometimes somebody comes to your house and, you know, your dog goes nuts. So it's, or they get excited when they hear the garage door open and they know you're home. So all of these things, they can be good and bad. If it causes excitement or causes them to react, cortisol is initiating all of these things to happen. Now, the issue when we're talking about Cushing's is that you're having a persistent high levels of cortisol when it's not needed. Again, we only need cortisol when we're kind of responding to this stressful event. So if you have ACTH and it's causing an excess cortisol, then this is how we develop Cushing's disease. But Cushing's, I don't have something called etiology for, you know, but it's like, what happens in the disease? This is what we mean by etiology. How does it normally start? How does it progress from a normal adrenal to this adrenal disease? It is more common in dogs than cats. Can be in cats, but it's seen more in dogs. And spontaneous Cushing's, middle to older dogs. So it's not a young dog disease. Sometimes it's around middle-aged to a little bit older age, depending on their breed. But there's different types of Cushing's that you need to know. The three types of Cushing's, there's something called pituitary dependent. That means it's because of the pituitary. There's adrenal dependent Cushing's, which is from the adrenal. And then there's iatrogenic Cushing's. Can anyone tell me what iatrogenic means? It's a very common term you need to know. That's idiopathic. If we call something idiopathic, like if an animal has idiopathic seizures, we kind of don't know what caused it. So that's idiopathic. Iatrogenic is caused from treatment. Oh, you're good. I appreciate you're trying. I mean, I'm getting silence, so I appreciate when you guys interact and take a stab at things. So, but that's good, because idiopathic, when you guys are in these disease classes, if something's idiopathic, it means we kind of don't know where it came from. Because seizures can be from like medications. Seizures can be from a tumor, and sometimes an animal has idiopathic seizures. They don't have a brain tumor. They didn't get into a toxin, and it kind of means that they just happened. But yeet, oh my gosh, you guys are cracking me up. So iatrogenic is something that's caused by treatment, meaning they were getting some treatment from the hospital, and that treatment caused the Cushing's. So iatrogenic usually happens because of treatment. So let me explain each one a little bit. So pituitary dependent means the pituitary gland is secreting excessive amounts of ACTH. They just keep so remember, ACTH stimulates the adrenal cortex. So the adrenal cortex is like, it's not my fault. He's telling me to release cortisol. It's getting that message. So for some reason, there's excess ACTH being released from the pituitary. That's why it's called pituitary dependent. It's a pituitary's fault. And the adrenal gland is just doing what it's told, and it's releasing excess cortisol. And this can happen because of hyperplasia. PG is pituitary gland. So now, does anybody know what hyperplasia means? If something has hyperplasia. Hyperplasia is an overgrowth. So for some reason, if there is what we call benign enlargement, hyperplasia is usually benign. It means for some reason that gland has what on earth? Come here. What do you want? There's nothing. Oh, you guys are ridiculous. Stop. Go. Stop. Okay. Stop. Okay. A plastic bag just blew into my yard, and my dog is insane. It literally is stuck in the... AJ, it's a bag. Well, that's actually perfect to describe what's stressful for my dog. A plastic bag blowing into my yard. Hey, let me pause this. I'm sorry. There's dogs are psycho. Okay. Save me from the dangerous Kroger bag. Okay. So so benign. So if something is if an organ has hyperplasia, then what happens is that if the gland is overgrowing, sometimes an area becomes hyperplastic, we call it, and it just overgrows. So like the prostate can have hyperplasia, the pituitary can have hyperplasia, and that means the tissue is normal, but it's overgrown. And when it overgrows, it tends to secrete more ACTH hormone. And therefore, you guys are cracking me up here. I'm trying to, but when you secrete too much, that's what's happening. And again, it's not, and this is said to be about 85% of cases kind of fall into this pituitary dependent category. There's also what's called adrenal dependent Cushing's. And in this case, there's potentially a tumor near the adrenal gland, or that's affecting the adrenal cortex. Now, whenever we say tumor, a tumor can be benign or malignant. Unfortunately, like in this scenario, you would have to typically do an ultrasound and potentially look at that adrenal gland and potentially biopsy it or, do some imaging. But if for some reason the adrenal gland is abnormal, and again, you're not going to pick that up on an x-ray. That would have to be like a CT scan or an ultrasound to kind of look at the characteristic of the adrenal gland. But that's maybe like 15% of cases. But then we fall into what can be fairly common is iatrogenic Cushing's. Now, if you remember, a glucocorticoid is the group of hormones produced by the adrenal cortex, but there is a drug group. Remind me, are you in Farm 1 or Farm 2? You guys said Farm 1, right? Thank you. Okay. When you guys get into the steroids as a drug group, steroids are actually synthetic glucocorticoids. When you give a dog prednisone, prednisone is a glucocorticoid in tablet form. So you got to follow me on this. And I think I've talked about this a little bit in anatomy. When you have a dog on prednisone, and a lot of times prednisone is, your dog has allergies, they're itchy, they have a rash. Prednisone is an anti-inflammatory. And so when you give a dog pred, it decreases inflammation, so the rash gets better, the itching gets better. But the problem is when you give a dog prednisone, then the dog is relying on that prednisone you're giving. And what happens is, then what's happening is it's reliant on that medical glucocorticoid, and then it affects the natural secretion of glucocorticoids from the adrenal cortex. So if we see what's called iatrogenic Cushing's, it's typically seen in dogs that have a history of prednisone, and a lot of times it's longer term. Like sometimes I'll tell you, if you take your dog into the clinic and your dog has allergies and they're like, we're going to put him on pred for 7 days. Usually, and this is very important from a tech's perspective, I always tell the client, usually we wean the pred down. So if you had like once a day for 7 days, then sometimes you do every other day for 7 days, and sometimes you do every third day for 7 days. Because what you're doing is you're taking away the synthetic glucocorticoid that you're giving, and now the gland can start to produce the glucocorticoid itself. So if you look, that's why it's really important for clients to understand when we give their dog pred, we don't just say give it for 7 days and stop. There's usually a weaning process. But iatrogenic Cushing's, there's some dogs that'll be on pred for like a year. The owner just keeps giving it and the vet keeps prescribing it. So when they're on it longer term, you have more of a chance of seeing this iatrogenic Cushing's than you do from a short course. But still, you should always do this weaning process. Now, I hate that these pictures are fuzzy, but clinical signs, they're very characteristic signs of Cushing's. One is kind of they look unkept. They just look messy all the time. But the big thing is they start to get abdominal enlargement. So they tend to, now, abdominal enlargement, but also muscle wasting. So the difference in, if a dog is overweight and their abdomen is enlarged, they're kind of enlarged all over. They have fat in other areas. In Cushing's, they've got this bigger belly, but the rest of their muscles kind of look sunken in. If you start to pet your dog and, they've got muscles, one area is you can find this are the muscles in the face. When they start to waste away, you can start to feel the cheekbones, you feel that occipital protuberance. Sometimes you go down their back and you can kind of feel some of their vertebrae, but then underneath they got this big belly. And some people are like, my dog is gaining weight. Well, but if you look at the rest of them, they're not necessarily gaining weight. They're kind of losing this muscle wasting. Can do some obesity. So you can see some also obesity. If they are intact, it can also affect the testicles, and they can start to, and when something atrophies, it means it's shrinking or it's kind of stopped growing. So instead of, so they kind of maybe start to shrink a little bit, they might start to look a little abnormal. Again, in alopecia, it does affect, and it's typically bilaterally symmetrical. So usually, because if you can see on this dog, it's maybe hard to see in this picture, definitely missing some hair, but it's usually the same on both sides. So it's not like it's just in one spot. Sometimes on their skin, you can actually have areas of hyperpigmentation. And sometimes that's more noticeable because they are missing the hair. You can now see the pigment of the skin. And some owners might say skin looks darker in certain areas, and that's the hyperpigmentation. Something that can happen later, and this is kind of interesting, it's called calcinosis cutis. And this is what happens. They actually get calcium deposits in their skin. I saw a boxer or English bulldog once with this, and it was like when you felt his back, the skin, instead of being able to kind of like grab and squeeze the skin, it felt hard. Like you couldn't even like pinch the skin, because within the cutis, or that layer of the skin, it's actually kind of gets these calcium deposits. It becomes actually hardened. And that can be seen in some advanced cases as this calcinosis cutis. Big thing here are the bottom, the polys: polyuria, polyphagia, polydipsia. So hungry all the time, drinking and peeing all the time. And what's interesting is also panting frequently. Now, obviously, when my dogs just went psycho, they're panting. But when they're walking around the house, they're breathing normally. These are dogs that are walking around like not after exercise, not after a hot day, not after being in the car, just being in the house like normal. They're panting. So kind of like feeling like they're hot, drinking, always peeing. So these are some, pretty common clinical signs. And again, so there's pot belly, missing hair, unkept appearance. So when we diagnose, number one, you start with your physical exam and your history, and then the owner complains of the polyuria, polydipsia, polyphagia, hungry all the time, all that. Pendulous abdomen. I don't know if you've ever heard that term, but if you think about a pendulum, if something is pendulous, it's kind of swinging. Well, the problem is their belly is big, and sometimes their muscles are wasting, and they come in and they've got this pendulous abdomen. So sometimes I'll describe a mass. It's a pendulous mass. So it means it's kind of a mass that's hanging and swinging. And so we use that term pendulous usually to describe an appearance of like a mass or the abdomen. They can get a pyoderma to the skin, so they may have some pustules, and maybe the dog's never had that before. That's kind of a newer thing. But the atrophy of the muscles, and then any history of recent corticosteroid treatment. Now, remember, there's pituitary and adrenal reasons. So they can have Cushing's without ever have had a steroid. So, but if they have these clinical signs and they're like, oh yeah, I've been giving my dog Pred for 6 months because he has allergies, you're kind of going ding, ding, ding. It's kind of pointing you in this direction. Obviously, you do your lab work and you're going to see potentially some liver chemistry abnormalities because of the effect on the abdomen and because of the effect on the body and this persistent cortisol. It can kind of activate the liver, and you'll see like ALP, ALT, and then you can also see a leukocytosis. Now, leuko is pertaining to all the white blood cells. So because they're in this persistent state, they get this release of potentially white blood cells. So you might have an overall elevation in that white cell count. And if you do x-rays, which sometimes the doctor says, sometimes we call them survey rads. They're like, let's just do abdomen and chest, and we're just going to kind of look at everything. Potentially hepatomegaly, meaning the liver can look enlarged because of this overactivation from the hormones. And potentially the adrenal glands do not normally show up on x-ray. It's a soft tissue structure. So normally you don't see an adrenal gland on an x-ray. But if there is a calcified area, like calcium deposits, sometimes you'll see, because calcium or calcified areas will show up on an x-ray. So sometimes near the kidney, you can see these little calcified structures that could potentially be in the adrenal gland. Usually if they see something like that, the next step is what I've mentioned here is an ultrasound. So what you got to do is an ultrasound will actually find the adrenal gland. And usually what a doctor does on ultrasound, it's kind of cool. They can take this little measuring device and they will measure how big the adrenal gland is. Because again, if it's enlarged, potentially an increase in the adrenal cortex or hyperplasia or a tumor can cause the excess release of cortisol. So, you know, measuring the size of the adrenal gland and looking at the appearance of the adrenal gland. And anytime I say ultrasound, plus or minus biopsy, you know, they have the option. The ultrasound doctor is really cool. They can take a needle, usually a fairly long needle, go in and potentially aspirate that adrenal gland. Now, this is where and sorry, this is kind of a small slide, but you guys have it on Moodle and you can zoom it. There's some special lab tests. And again, most conditions like this, you're going to do a CBC chem. You're not usually going to say, let's skip a CBC chem and let's just do the special testing. Because remember, in some of these diseases, they can affect the liver. They can affect the white blood cells. They could affect potentially the kidney. So usually when we suspect these diseases, you're going to want to do a CBC chem to kind of get a picture of where are we starting and what is being affected. And then now these are the tests that are going to give us the definitive diagnosis. Everything I've talked about thus far, right now we're just suspecting. We're like, we suspect it's adrenal disease. So a couple different tests that you can do. One of them that's the most common is called the ACTH stim test, stimulation. So they you know, doctor said, let's do an ACTH stim. So this one is fairly kind of time consuming, but what they do is the patient will fast in the morning. Normally we fast them. And they come in the morning, and when they come in, you're going to draw a blood tube. I believe it's usually a serum separator tube, but your lab book, when you're in practice, there is a book that'll tell you this is the test you want, and it'll tell you what kind of tube you need. And then you'll remember the next time you do it. But if you ever have questions on what blood tube do I need for a special test, your lab will always have, usually the clinic has a lab book that tells you this test needs this tube and how do you handle the sample. But so you collect the blood in the morning, you're going to label that pre-sample or sample number 1. And then what you're going to do is you're going to administer IV synthetic ACTH, and it's actually called cortricin. So now obviously ACTH comes from the pituitary gland. So we have to give the animal a synthetic injectable version. And so cortricin is a drug, and that is actually synthetic, man-made ACTH. And what you're going to do is you're going to give that IV, and you're going to record the time. So say you did all this, say at 8 a.m. you draw the first sample, 8:15 a.m. you give the IV cortricin, the doctor will give you a dose, and then an hour later, you're going to draw another blood sample, and you're going to label this sample 2 or post cortricin. As long as you have the tubes labeled, you know what was your pre-sample, and then an hour later, you're going to do another one. Now, those are going to be, now, a lot of times these tests may take a day or 2 to come back. So usually you're not going to find out because you don't do these in-house. These have to go to the lab. But what you're looking for is what are the cortisol levels? And usually if cortisol is greater than 20 micrograms per deciliter, that is consistent for Cushing's disease, because what you expect, if this animal was normal, say didn't have Cushing's, and you did this test, ACTH should cause a release of cortisol. But if they're Cushingoid, the glands are so sensitive to the ACTH that you gave, the ACTH would cause a release of cortisol, and you would see an exaggerated response. Okay, so what we're looking at here is in a normal animal, what do you expect? If they're Cushingoid, what do you expect after you give them cortisol? So right here, if it causes release of cortisol, they're more sensitive to getting ACTH, and it causes a release of large amounts of cortisol. So for example, if they were normal, we would be under this 20 number. We would expect lower. But because they're sensitive to that ACTH, you're getting kind of a release, an excess release of cortisol. That's one type of test you can do. You can also do what's called, and this is abbreviated, LDDS, or low dose dexamethasone suppression test. So kind of similar, they fast, collect your blood in the morning to get a resting cortisol, and then you're going to inject dexamethasone. Now, dexamethasone, if you've never heard of it, is an intravenous steroid. Usually we use dexamethasone to, if the dog has like a bee sting and they're having they have a reaction to a vaccine, if they're like swelling up and they're having a reaction to a medication. So normally IV dexamethasone is used as an emergency steroid treatment. Okay, because it's quick acting. So normally what you do in this, you're going to inject dexamethasone, which is a corticosteroid, which is a glucocorticoid, IV or IM, depending on what your doctor says. And then in 4 hours, time it, you're going to draw a sample. And then in 8 hours, you're going to draw another sample. So this animal will be at your clinic all day. So you have your AM sample, give your injection, 4 hour sample, 8 hour sample. If cortisol is above that 1 microgram per deciliter, then after 8 hours, then that's suspecting of Cushing's. If you had a normal dog, your cortisol would be lower than that 1 because it's been 8 hours. So again, if you give the injection and you're getting levels of above 1, then that's positive for Cushing's. And these tests are not super simple tests to remember. Usually it's funny, when normally they come in for this testing, we're all kind of like going through the book and I'm talking to my doctor. So I don't, memorizing this would be very difficult. Usually when they come in, we all have to kind of go, okay, I talk to my doctor. I'm like, what's the dose you want of Dex or Cortrosyn? When do you want the samples? And we kind of all talk about it. Now, you can also do something called a high-dose Dex suppression test. You do it the same way, 0 hour sample, and then you go to the 4 and 8 hour, except you're using a higher dose of dexamethasone. If a doctor does this, they're trying to determine if it's pituitary or it's adrenal dependent Cushing's disease. Like I said, probably the gold standard is the ACTH stim test. But the problem is you do have to have Cortrosyn in your hospital. Dexamethasone is dirt cheap. So maybe the doctor is going to do a dexamethasone test, maybe because they don't have Cortrosyn. They may not have that medication, or they prefer to do this test over that. So it could be doctor. It could be what medication, because I'm going to tell you, almost every clinic will have a bottle of dexamethasone. Will you necessarily have a bottle of Cortrosyn? Cushing's is fairly common, but it's not like every other patient's coming in with it. So if it's a specialty hospital, they're going to have Cortrosyn. We had Cortrosyn. So are there questions about this so far? There is a special test you can do called a urine cortisol creatinine ratio. And in that situation, basically what happens is the owner collects the morning urine. So they're going to collect it in a dish at home, first urine of the morning, and they're going to bring it up. And then what they're going to do is they're going to measure the ratio. This is my 4th lecture. I can talk. the ratio of cortisol to creatinine in the urine. And what they're looking for is if cortisol would be like 30 times the level of creatinine, that much higher than creatinine, that can be diagnostic. So if they have such a level of cortisol, remember something about urine. Sometimes what happens when we have elevations of chemicals in the blood, they will spill into the urine. So sometimes urine can be used to back up blood tests. When I get into diabetes, this is important about glucose. But again, if creatinine is at such a, or I'm sorry, if cortisol is at such a level that we're seeing 30 times the level compared to creatinine, then that would be indicative of, and again, that's one also that has to be sent to the lab. And the reason we have the owner collect it is it would be very hard to wake up your dog after sleeping all night and get them in the car and get them to the vet without them urinating somewhere. And this type of sample does not need to be clean. You know, we're not testing for a UTI, you know, so the owner collecting it at home, it doesn't need to be a clean sample. So it's going to be better that they collect it in the morning, stick it in the fridge, get it to you as soon as possible, and then you guys send it to the lab and then measure that amount. It's 2:20, so let me just talk about the medication so we can kind of tie up Cushing's. Medication, it is treatable. There's a drug called mitotane, which is known as Lysadrin. Lysadrin is the trade name. And what this drug will actually do, think lysing, destroying, if that helps you remember, but it'll actually cause necrosis of the adrenal cortex. And what this does is actually, if you necrose it, now necrosis is where tissue dies. So this drug is kind of trying to destroy the adrenal cortex. So what do we worry about? Well, if we're destroying, so SE is side effects. Obviously, if you get excessive necrosis, then we're going to cause a deficiency. Then what happens is the adrenal cortex, what they're trying to do is we're trying to cause some necrosis, but still allow some glucocorticoids to be produced. So managing this drug is kind of causing necrosis without like completely destroying it, okay? So if there's an excessive necrosis, then you have a deficiency in glucocorticoid and mineralocorticoids, and that's going to could lead to Addison's disease, which is the opposite of Cushing's. So that is, there's also acetylcholine hydrochloride, which anapril, not enalapril. I started to say that because that's a heart medication. Anapril actually decreases ACTH production by the pituitary. So if it's pituitary dependent, you would use anapril. If it's adrenal dependent, you're going to use probably Lysadrin. So the doctor will have to decide, is it the pituitary's fault? Is it the adrenal gland's fault? By doing all this testing, then they can find out which medication. The ketoconazole is a medication, and this one can actually inhibit the enzymes that help cortisol synthesis. And if you kind of inhibit those enzymes, naturally, you're going to decrease those levels. And again, once the doctor gets to the root cause of the, Cushing's, then they can choose the appropriate medication. Cost can be a factor. I don't think Lysadrin is very cheap, if I remember. Of course, I'm old. It's probably come down in price now, but it was fairly expensive. I will say, and I will only mention this, is if for some reason there is an abnormal growth in the adrenal gland, that's, so it can be if there is an adrenal tumor. There's actually a type of tumor. It's actually called a pheochromocytoma. A pheochromocytoma, people call them pheos, are actually a tumor in the adrenal gland, but it's an extremely, extremely risky surgery. I've been in on 2 pheochromocytomas, and the problem is when you mess with the adrenal gland in surgery, Well, I'm going to show you a quick picture. I'm going to jump ahead. These are the adrenal glands. There's your vena cava and aorta. So the problem is, anytime you're going to operate on the adrenal gland, you got some big blood vessels. And sometimes if they have a tumor, that one case I saw, we actually had to euthanize it on the table, the tumor was growing into the vena cava. So as the doctor was trying to kind of cut away the tumor, as soon as he peeled away part of the tumor, the abdomen just started filling with blood. It was like you opened a faucet and the blood, and the owner knew that this was a risk. This was a very risky surgery. The owner was prepared, but it was unfortunate. But the nature of the tumor, it invaded the vena cava, and there was no way, it's almost impossible to try and sew the vena cava back together because the amount of blood. So this is not an easy surgery. This is, you need to be at like a specialty center, a boarded surgeon. You're not doing this at a GP. They need to go somewhere special, teaching hospital. During this surgery, they can get spikes in blood pressure and plummets in blood pressure. There was like a team of 4 of us doing anesthesia. It's just that critical. So adrenal surgery is not like for the faint of heart, but surgery could potentially be an option if the owner, there's a lot of workup to determine, is surgery going to fix the problem? Most of the time, standard Cushing's, it can be done with medication, but if there isn't a growth, surgery can be done. Lifespan is kind of guarded. It depends on where they are in their Cushing's, early stage, late stage. Average lifespan is 2 years after diagnosis because of the effects that it has on the body. And sometimes it's complications from the treatment, from the necrosis, from the cortisol, and sometimes the effects of Cushing's on the other organs are also what can limit the lifespan. If it affects the liver, and then potentially there's liver damage, that's not reversible. So again, treatment available, may not get long life, but so are there any questions about Cushing's disease? It's kind of a little complex to understand initially.